Hi, everyone. Thank you so much for joining today's call. I am just going to start sharing my screen and we'll get started. Great. Hopefully everybody can hear, see, and see the slides. So again, thank you so much for joining today's call. My name is Hayden Leeds. I'm a first-year critical care fellow at Children's Hospital Los Angeles. And today we'll be discussing the use of EIT in pediatric patients in our ICU. Before I get started, I did want to just provide a few disclosures. We do receive equipment and supplies, as well as technical support from Temple Medical for our ongoing research that we're conducting at CHLA. I will begin by providing just a quick summary of our objectives and kind of an outline for today's talk. I'll begin by providing an overview of electrical impedance tomography and orient you all to the information available at the bedside. I will then discuss an example case of a patient with severe ARDS and ventilator-induced lung injury, in whom EIT was very helpful in guiding clinical management. We'll then shift gears and I'll discuss some lung protective ventilation strategies in pediatric ARDS. I will then discuss EIT's role in guiding management at the bedside, with a particular emphasis on PEEP strategies and an ongoing study that we're conducting at CHLA looking at PEEP management using EIT in pediatric ARDS. We'll then discuss the concept of recruitability and how it applies to PEEP management. And then finally, we'll end by discussing other applications of EIT in the pediatric ICU. So as the video showed, I would like to just kind of go over an overview of EIT for those that may be less familiar, or as a review for those that have used EIT previously. So EIT is a technology that encompasses a belt that's composed of 32 electrodes. It's positioned between the fourth and fifth intercostal space. Each pair of consecutive electrodes delivers a continuous electrical current. The variation in the impedance of the tissues that it crosses is captured by the other electrodes during a rapid rotation around the thorax. This variation of a lung impedance induced by ventilation is then converted into a bidimensional lung image, which is displayed on the screen. The dynamic image, which is this image here in the center, is the real-time image of ventilation occurring in the patient in front of you. The image in the bottom left is called the tidal image, and this is the average of the last several breaths. And so you can start to see patterns of ventilation and inhomogeneity or homogeneity, depending on the particular case. You can then divide up the lung into several different regions of interest. So you can have anterior, posterior, right, and left, to get a sense of how the ventilation is mapped or may be differing in different areas of the lung. As part of the technology, it comes with a inline flow sensor. So this is attached directly to the endotracheal tube. And this allows us to not only see ventilation, but also pressure and volume measurements, as well as the machine itself is able to calculate different lung metrics, such as driving pressure, the PEEP, the PIP, as well as intrinsic PEEP. If this patient had an obstructive process, you can also start to see measurements of compliance, resistance, and then the tidal volume. And so this is a really helpful tool that can be attached, continuously monitoring these patients at the bedside. I believe the manufacturers allow the belts to be in place for up to 48 hours before they have to be changed. And so again, for patients that are requiring lots of different titrations, it's very helpful to kind of monitor over time. In the introductory video, you may have seen this image already, but this is just a representation of how those electrodes are continuously conducting electrical signals and how the adjacent electrodes are then taking that and producing the image that we see on the screen. Here's a simulation video of what you would actually see at the bedside in real time. So again, you have the dynamic image in the center of your screen. You have the various lung mechanics on the right side of the screen, which are coming from the flow sensor. And then you have that tidal image, which is the average over the last several breaths with the plethysmogram and the impedance at the bottom. And so we can see that this patient is ventilating about 60% to the right lung, 40% to the left lung, which is a fairly normal homogeneous pattern. Now I'd like to shift gears and discuss a representative case for how we have been able to use EIT at the bedside in our pediatric ICU. So this is a complicated case. This was a patient, previously healthy 7-year-old male, who was transferred to our facility after several months of management at an outside hospital where he had severe ARDS secondary to adenovirus pneumonia. He then went on to develop multi-organ dysfunction and the need for continuous renal replacement due to renal failure. During the course at the outside hospital, he was on high-frequency oscillatory ventilation for up to 6 weeks. And in the process of transitioning from conventional to high-frequency ventilation, he underwent several cardiac arrests. Most notably, he had high-frequency settings as follows. At the outside hospital, his amplitude was a 60 centimeters of water with a mean airway pressure of 37 centimeters of water and a frequency of 5 hertz. The highest documented amplitude at the outside hospital was 65 centimeters of water with a mean airway pressure of 48 centimeters of water. As you are listening to those numbers, many of you are probably pondered by how high those settings were. Not surprisingly, he went on to develop pretty severe ventilator-induced lung injury requiring up to 8 chest tubes. After months of management at the outside hospital, the referring team finally consulted us and ultimately wanted to transfer this patient for consideration of tracheostomy. This was his initial imaging upon arrival to our facility. And as you can see, he has, again, very severe ventilator-induced lung injury. The image on the left is his chest x-ray, and the image on the right is a CT scan done around the same time. I want to point out that he has these large right-sided pneumatoceles that were likely due to repetitive barotrauma with very little lung parenchyma present on that right side. And then on the left, he had, again, a pneumothorax or pneumatoceal with the presence of one of the chest tubes. The others had been removed at this time. And this chest tube had a persistent air leak that was causing some issues. Early in his course, we decided to perform electrical impedance tomography to get a better sense of the inhomogeneity in his ventilation. We had previously had those CT scans and his chest x-ray, but we wanted to get a sense of how much ventilation was going to the right versus the left lung. These were his ventilator settings at the time of EIT and upon transfer to our facility. So he was on a pressure control SIMV mode with a peak pressure of about 24 centimeters of water. His PEEP at that time was 8 centimeters of water. His respiratory rate was 24 breaths per minute, and he was getting tidal volumes of about 10 mils per kilo with those settings. He was on 40% FiO2, and then his P0.1 was 5 to 7. And what is P0.1? This may not be a common metric for many of you. So this is the negative deflection in airway pressure that occurs in the first 100 milliseconds of every breath, and this is reflective of patient effort. We normally think of a normal value as being less than 3 to 4 in the pediatric population, and so 5 to 7 is quite elevated, suggesting that he was having quite a bit of respiratory effort even on those ventilator settings. You can see his EIT image on the right here, and what I want to point out is that areas that are more ventilated are lighter in color, and areas that are less ventilated are darker in color. And so as you can see, he has a predominant ventilation going to his left lung. And the EIT image was able to tell us that about 70% of his ventilation was going to the left lung, with very minimal ventilation going to that right lung, likely in the setting of those large pneumatoceles and the collapsed lung parenchyma. I will say, though, at this time, it was unclear what was actually happening in the right lung. Was that collapsed lung tissue? Was that necrotic lung tissue from his severe pneumonia and kind of evolution of his disease? Or was that simply collapsed lung tissue, viable lung tissue that could be re-recruited? And we really didn't know the answer to that at the time. It was also interesting to note that the EIT was able to actually show the presence of that air leak, which was something that I had not seen before. And as you can see in the image here, this is a screenshot taken at the bedside. You can actually see the air leaving through what was presumed to be a bronchopleural fistula with that persistent air leak coming out of the chest tube. But again, we knew that 70% of the ventilation was going to the left lung, but it was unclear exactly how much was being lost through the bronchopleural fistula and the air leak. And so that kind of was the question that we were posed with at the bedside. And so the team ultimately elected to perform a bronchoscopy on this patient. This is a sample image of the bronchoscopy. As you can see, this is coming down the left in stem bronchus and looking at the 3 takeoffs of the left lung. It was presumed that the air leak was originating from the lateral segment of the left lower lobe. At the time of bronchoscopy, these were his ventilator settings. So again, he was on pressure control SIMV mode, which is a pretty standard mode for us in pediatrics. Those adult respiratory providers on the call may be more familiar with volume control ventilation, but again, in pediatrics, we use primarily pressure control. His ventilator settings had increased at this time due to persistent hypercapnia. His peak pressures were now 30 centimeters of water with a PEEP of 10 centimeters of water. He was getting about 8 cc's per kilo of tidal volume with these settings. At the time prior to the actual bronchoscopy, his FiO2 was about 35% and he was satting 98%. The ultimate decision to proceed with bronchoscopy was in order to introduce what's called an ARDS blocker. So this is a device that we were able to place into the airway, block off particular segments of airway. And the hope was that by introducing this blocker, could we potentially leave it in place, allow that bronchopleural fistula or air leak to heal, and eventually have healing of that air leak so that we could then focus on other areas of the lung. Unfortunately, the patient had increasing CO2. This may have been due to the actual obstruction of the endotracheal tube during the bronchoscopy, and so it's unclear how much of that was due to that versus the actual introduction of the ARDS blocker. So his ventilator settings were increased to a PIP of 38, which is pretty high settings, with a PEEP of 10. Now he was requiring 100% FiO2 to maintain SATs of 84%. So ultimately, the endotracheal blocker was not left in place as he clearly was not tolerating this. And the question became kind of what was happening on that side of the lung and maybe what was happening with specifically perfusion. So lucky for us, EIT does have an ability to see lung perfusion. We are able to do this via an offline analysis, which is called the pulsatility feature. This measures the amplitude of cyclic changes in the lung impedance caused by the passage of the cardiac stroke volume through the lung. And so the EIT belt itself actually has built in an EKG that is able to, normally we would negate the cardiac signal to get the ventilation image, but we can actually use the opposite for the purposes of looking at pulsatility and perfusion. As you can see, his perfusion is equally matching his ventilation. So most of, if not all of the perfusion was going to that left lung. And when the patient became desaturated during this episode, it suggested that he was having a worsening VQ mismatch. So now that we blocked off the left lower segment, he was not having any ventilation, but continued to have most of his perfusion going to that area. And so this was worsening a likely already present pulmonary shunt. So with this knowledge, we now knew, okay, we have a persistent air leak, and we also have this very minimal lung parenchyma on the right side. And so how are we going to address that? And ultimately, it was felt that the patient was not going to tolerate positive pressure ventilation, or with positive pressure ventilation was likely not going to have resolution of those processes. The patient was actually in the process of being worked up for possible lung transplant. And then as a kind of turn of events, the patient went on to require VV ECMO. This was due to acute decompensation one evening, and the patient had an event. It was unclear what exactly happened, but it sounds like, talking to the providers that were there, that he may have had like a mucus plug or something that caused him to have severe hypercapnia that needed rescuing. And so he was ultimately cannulated to VV ECMO. And this proved to be actually very beneficial, as it allowed ample time for long rest and minimal ventilator settings to allow the air leak to eventually heal. Over the course of his run on VV ECMO, the air leak did go away. We were able to clamp the chest tube, and at that point, with the left side kind of tampered, we were then able to focus on the right side of the lung and those persistent pneumatoceles. And so again, the question continued to be, would the collapsed lung tissue, would it be recruitable, or was this purely necrotic lung tissue? But the only way to figure that out was allowing ample time for resolution. And it was not felt that he would be amenable to reduction of those pneumatoceles with a surgical procedure. So ultimately, the patient was selectively intubated while on ECMO. So we had the ECMO circuit doing most of the oxygenation and ventilation. And so we were able to place, via the bronchoscopy, we were able to place the endotracheal tube into the left mainstem bronchus, allowing for full healing of the right side. And here is a chest x-ray that was done after the selective intubation of the left mainstem bronchus. And as you can see, the endotracheal tube is now placed in the left mainstem bronchus with almost complete collapse of his right lung. Here's his VV ECMO cannula in the heart. And over time, we can see that he now had the resolution of the left-sided air leak with the removal of the chest tube. And over the course of his several-week VV ECMO run, the endotracheal tube was able to be slowly retracted, allowing for more ventilation going to the right lung. And as you can see, he's already starting to have some re-recruitment of his lung parenchyma in resolution of those pneumatoceles. So in conclusion of this case, I think it was a very exciting and rewarding outcome for this particular patient. He went on to be decannulated from ECMO and had almost complete re-recruitment of that right-sided lung parenchyma. So it was viable lung parenchyma, not necrotic tissue. He was eventually able to be extubated and finally was actually discharged home on room air after about a month's stay of inpatient rehab. And he's doing quite well to this day with no ongoing respiratory support needs. The image in the top left shows his chest x-ray at the time of discharge. And as you can see, he has a relatively normal chest x-ray with almost complete resolution of any of those pneumatoceles and fairly normal aeration pattern bilaterally. The chest CT image shown there was taken around the time of his ECMO decannulation. And as you can see, it just highlights, compared to the images that I showed earlier, the re-recruitment of that lung parenchyma. And he does have a little bit of wedge atelectasis here, but overall a pretty normal or relatively normal chest CT given his earlier presentation. And this was EIT that was done at the time of that same CT image. And as you can see, he has a much more homogeneous pattern that's fitting with his CT. And not only is the ventilation more homogeneous between the right and left lung, but also the perfusion and the pulsatility is matched. I will note that the red is lung perfusion and blue is perfusion related to the heart. And so not only does this case highlight the importance or the role of EIT for monitoring at the bedside, both ventilation and perfusion inhomogeneity and guiding clinical practice, but it really drives home this point of adherence to lung protective ventilation strategies and guidelines. And so what are those strategies in pediatric ARDS? Back in 2022, there was a consensus statement with world-leading experts that convened to come up with guidelines for the management of pediatric ARDS. These were called the PALC-2 guidelines and are kind of the mainstay for our therapies in the pediatric ICU when it comes to ventilation strategies. Some of these recommendations will likely look familiar to many of you, especially those that are adult respiratory therapists on this call, as they're taken from adult literature. Unfortunately, there's a paucity of randomized control trials in pediatric ARDS, and so we have had to use a lot of adult studies to guide our management in pediatrics, and hopefully we'll have more randomized trials coming in pediatric ARDS to either show that we have similar findings in pediatrics or different findings and thus need to adjust our management. But for right now, this is what we have. So I do want to draw your attention to both the tidal volume and the pressure limitations to effectively guide kind of lung protective ventilation strategies. So first, Dr. Amato published in his New England Journal of Medicine paper that there was a mortality benefit for those patients in which the driving pressure is limited to 15 centimeters of water or less. And so that's where this driving pressure less than or equal to 15 comes from. And that equates to about a plateau pressure of less than or equal to 28 to be lung protective. The ARMA trial, which was another adult study that was done by the ARDSnet group, found this was a trial that randomized patients to either a low tidal volume or a more standard tidal volume. So the low tidal volume was 6 milliliters per kilogram of tidal volume versus a high tidal volume strategy of 12 milliliters per kilo. And they found a mortality benefit in the low tidal volume group. So much so that this trial was actually ended early. And so this is the basis for a lot of our tidal volume limitations and strategies in both adults and pediatrics. And so generally we think of safe tidal volumes as being anywhere from 6 to 8 mils per kilo, but sometimes we'll actually tolerate lower tidal volumes of 4 to 6 mils per kilo in patients that may have worse compliance and in which we're trying to limit the driving pressure and the plateau pressure. And so how is EIT helpful in guiding these kind of lung protective ventilation strategies? The same group that we'll talk about later in the study out of Brazil, Dr. Costa and Dr. Amato, they are leading the charge with a lot of this EIT research. And they actually performed a phase 2 randomized control trial during the COVID-19 pandemic, in which they randomized patients to a more conventional strategy of following the ARDS guidelines, and then that strategy that was using EIT guided management. And what they found is that the patients that were in the EIT guided management arm had generally lower driving pressure, generally higher PEEP, and then lower tidal volumes. And so generally were managed with a more lung protective ventilation strategy. And then interestingly for their outcomes, they found that patients that were in the EIT guided ventilation strategy group had a decreased time from randomization to breathing comfortably on room air, suggesting that there was not only benefit in the lung mechanics, but also their overall outcomes. And so this is an exciting paper that I think just highlights the importance of EIT in being this kind of way of monitoring at the bedside in real time. So what about PEEP? I think PEEP is a really important and interesting parameter when we think about ARDS. As many of you know, a hallmark of ARDS is this oxygenation abnormality. And PEEP is often utilized to improve oxygenation. And it also allows us to limit our driving pressure and achieve more lung protective ventilation strategies. An ideal PEEP is one that promotes or recruits collapsed lung tissue, but it also has to limit overdistension so that it doesn't cause more barotrauma or hemodynamic changes. As we know, ARDS is a syndrome and it's very heterogeneous. So different alveoli in different parts of the lung may have varying time constants and may be affected by PEEP differently. And there's this notion of recruitability, which was defined by Gattinani et al. In their New England Journal of Medicine paper back in 2006, that showed that there was a mortality and morbidity benefit for patients that were found to have more recruitable lung disease. And so what is recruitable lung disease? In the image on the right, we have two different patients, one with recruitable and one without recruitable lung disease. And so recruitable lung disease is lung disease that is able to be overcome with higher PEEP or higher pressure, so areas of collapse that you can overcome. The patient on the top would have non-recruitable or low recruitability. So this patient has some areas of collapse in these more posterior lung areas, and going from 5 to 45 centimeters of water, so a pretty significant recruitment maneuver, they really don't have much change seen on CT in terms of atelectasis or collapse. Conversely, the patient in the bottom of the screen, again, has areas, pretty significant areas of collapse, more in these posterior areas of lung. And when they undergo a recruitment maneuver from 5 centimeters of water to 45 centimeters of water, a lot of this area of atelectasis or collapse is overcome, suggesting that they may have recruitable lung disease. So what about PEEP and pediatric ARDS? Again, most of this is based on adult literature, but we do have, this was actually one of the few markers of evidence for the PALIC-2 recommendations that does have a moderate certainty of evidence. And that is, the recommendation is that we keep PEEP at or above the low PEEP FiO2 table recommended PEEP. And where does that come from? This comes from literature that is published in the pediatric realm, specifically some of the work done out of our group at CHLA with collaboration from other groups. And it showed what they found is that patients that had PEEP that was maintained per the PEEP FiO2 table recommendations or above actually had lower mortality and morbidity, suggesting that they may benefit from this kind of higher PEEP strategy. And so that was the basis for the PALIC-2 recommendations. More importantly, this is kind of a one-size-fits-all approach. We know that the ARDS PEEP FiO2 table is kind of a crude metric. It just really takes how much FiO2 are you on and what is your PEEP. And sometimes there's a wide range of PEEPs that are recommended. It doesn't take into account much in the way of patient-specific characteristics. And so not all patients may benefit from a higher PEEP strategy or may benefit from PEEP in the same way. And thus we need a reliable tool at the bedside to guide management. And this is where EIT comes in. So the EIT device actually has a PEEP titration tool built into it. This is a representation of what the report would look like when performing the PEEP titration tool at the bedside. So I'll just take a little bit of time to orient you all to the screen here. So first, PEEP titrations should be done during decremental PEEP titration or decremental PEEP trial. This is to limit any confounding with tidal recruitment and lung hysteresis. So during the inflation limbs, the patient may have reduced compliance, and as the patient is undergoing decremental, you may have some tidal recruitment and the phenomenon of lung hysteresis. And so it's important that you do this during decremental PEEP phases. So depending on how you are wishing to do your decremental PEEP steps, you can set the time. So normally I do about 2 minutes, and I'll talk a little bit more about this later, to allow for kind of complete equilibration of all of the lung mechanics at each step. For the tool itself to work well, these steps, there needs to be at least 6 steps for it to get a true pattern of what is happening. So this technique and the device itself takes into account what's called the crossing point technique. This was defined by Dr. Costa out of Brazil, and this defines the ideal PEEP as one that is, again, matching overdistension and collapse. So looking at the different lung units, the different lung pixels, it's able to see where every part of the lung is on the compliance curve. And depending on whether you're on the right or left side of the compliance curve, it can quantify overdistension or collapse. The tool then at the end is able to give you a graphic representation of collapse, overdistension, as well as compliance. The images on the top show both the plethysmogram, which is the impedance changes at every step, as well as the pressure. So you can see as during the decremental PEEP, the PEEP is lowered every 2 or so minutes. The orange line is your compliance, so a nice U-shaped curve. The white is overdistension, and the blue is collapse. And so where those two meet would be the ideal PEEP. And so for this particular patient, the ideal PEEP would be about 15 centimeters of water. And as you can see, once they get to lower PEEP levels, they start to have quite a bit of collapse versus overdistension at higher PEEP levels. And then that's represented here on the right, with areas being white are overdistension and areas that are dark blue are collapse. And so at every PEEP level, you can see not only the compliance, but overdistension and collapse, and can start to really tailor your PEEP management at the bedside. So this is a really exciting new tool and way of managing PEEP in ARDS. And so we're actually conducting a trial right now at Children's Hospital Los Angeles, in which we're comparing the PEEP strategy based on EIT to the more traditional gold standard of the ARDS PEEP FiO2 table. Our primary aim is to compare the ideal PEEP recommended by EIT versus PEEP recommended by the ARDS low PEEP FiO2 table. We're also hoping to determine the difference in physiologic metrics between EIT optimal PEEP and the PEEP FiO2 recommended PEEP, as well as exploring patient and physiologic variables associated with increased recruitability as measured or identified by EIT. And again, recruitability is going to be defined as that amount of collapse that is overcome with increasing PEEP, which I'll show some examples of later. And so here's an example of, or a schematic of our PEEP titration that we are doing at the bedside. This is our research protocol, but I really do think this is a viable strategy for any respiratory therapist or provider on the call when assessing patients at the bedside. And most notably, I want to point out that I think it's really important that providers do a recruitment maneuver for the reasons that I mentioned earlier prior to doing any decremental PEEP titration. Sometimes I think there's a thought that you go into at the bedside and just start turning down the PEEP to see. But if you really want to get a sense of kind of what is happening with the compliance of the patient, it's important to recruit them prior to doing the decremental PEEP trial. And so what we do for the purposes of our research study is in increments of 2 minutes, we increase the PEEP by 2 centimeters of water up to a maximum of 20 for our patients, just for patient safety, or 6 centimeters of water above their clinical set PEEP. And then we perform the decremental PEEP trial, again in 2-minute increments, occurring every decreasing the PEEP 2 centimeters of water every 2 minutes, down to a minimum of 6 centimeters of water or a PEEP of 6 below their clinical set PEEP. I then recruit the patient for a 5-minute interval at the end of this and return them to their baseline PEEP. This data is then shared with the clinical team, and then they can elect whether or not they want to use the recommendations based on EIT. So here are some examples of some of the reports that are produced from this PEEP titration tool. So this particular patient was on a FiO2 of 40%, saturating 95%. And so their PEEP FiO2 table recommended PEEP would be 5 to 8 centimeters of water, and their EIT recommended PEEP is 9. So pretty in line with the PEEP FiO2 table. The report also gives you not only their PEEP, but also the compliance, as well as the quantification of overdistension and collapse. And you can see that in the different curves here. So again, blue is overdistension, red is collapse, and then green is the compliance curve. And I would like to draw your attention to not only the crossing point, but also the compliance curve. Many of you are probably familiar with titrating PEEP at the bedside to target PEEP of best compliance. And this is a great starting point. What we are starting to notice in our study is that compliance does not always line up with the crossing point between overdistension and collapse on EIT. And thus, we're hoping this study will shed some light into PEEP titration strategies in pediatric ARDS moving forward. Here's another example. So this patient is on 60% FiO2, setting 95%. The EIT recommended PEEP would be 12. In this patient, their PEEP FiO2 table recommendations is 10. So this patient has a PEEP slightly above the PEEP FiO2 table recommended PEEP. And as you can see, it's pretty in line with their compliance. So both the crossing point and compliance is kind of occurring at the top of the compliance curve. And then finally, there are some patients that their EIT recommended PEEP is below that of the PEEP FiO2 table. And I think these are probably the patients that we're most interested in. I think for this particular patient, they were on 100% FiO2, only setting 92%. So had a pretty severe oxygenation abnormality. And the PEEP FiO2 table would recommend that their PEEP be anywhere from 18 to 24. And this is a really wide range. And as a clinician or a practitioner at the bedside, it can be hard to know, do I choose 18, do I choose 24, or do I choose something in between? And so the EIT is able to give us a little bit more nuanced or tailored approach. And again, this is showing that the crossing point is slightly different than that of the compliance. And so how does EIT help us identify recruitable or non-recruitable lung disease? Again, this is a really exciting area because we've known from adult studies that the presence of recruitable lung disease is associated with mortality and morbidity, being that more recruitable lung disease has lower mortality and morbidity. So recruitable lung disease would be one, again, where collapsed lung tissue can be overcome with higher pressures or after a recruitment maneuver. And as you can see in this particular example, this patient, they were recruited up to a PEEP of 20, and then during the decremental PEEP steps, they were taken down to a PEEP of 8. And in doing so, they start to have quite a bit of lung collapse that's occurring at the lower PEEP levels. So even at a PEEP of 12, they're starting to have some collapse in those posterior areas of the lung with a total collapse of about 35%, so pretty significant, suggesting that they may have more recruitable lung disease and may benefit from a higher PEEP strategy. So in comparison, we have a patient here that would be considered as having non-recruitable lung disease. And again, patient is recruited up to, in this case, up to 16 centimeters of water. At this higher PEEP level, they start to have quite a bit of overdistension, as seen with this kind of lighter white color here in the top left image. And as the PEEP is decreased all the way down to 6 centimeters of water, we really don't have much in the way of collapse, with only about 1.2%. And it's not even represented here in the image because it's so small. So this patient may just have detrimental effects by increasing PEEP and may not benefit from that higher PEEP strategy. It's also interesting to note that as the PEEP is decreased, their compliance continues to increase all the way up to 29 centimeters of water. So if you were at the bedside and you didn't have EAT, or you did have EAT, you may see just by looking at PEEP of best compliance that this patient would benefit from a kind of a lower PEEP strategy. So now I want to turn gears to other applications of EIT and other kind of future directions of what we're exploring with our own research at CHLA. So this next case that I'm going to discuss, this was a 7-year-old patient that was intubated for severe asthma. The team had asked me to perform EIT on this patient because they were having difficulty weaning the patient from the ventilator. And they wanted to know if there was maybe some regional heterogeneity that could explain the lack of improvement and the inability to separate the patient from the ventilator. So at this time of EIT, the patient was simply on kind of a CPAP trial, and they were unable to pass. So our standard kind of SBT or spontaneous breathing trial in our PICU is we put the patient on a CPAP of 5. We usually do this for several hours, and we're monitoring for changes in vital signs as well as work of breathing. And this patient was continuing to fail their SBT for work of breathing. And what we found when we did EIT is kind of what we would expect for an asthmatic. They were quite overinflated, but then they had this really prolonged exhalation phase. And as you can see, they really delayed emptying in both lungs. And so it begged the question of what can we do to overcome this and facilitate successful extubation? Again, just delayed emptying here. So at the bedside, I increased the patient's CPAP or PEEP from 5 to 8 centimeters of water. And what was most notable, I'll show the EIT image here in a minute, but what was most notable was the patient actually had almost instantaneous reduction in effort of breathing. This was measured at the bedside by looking at the patient's subcostal retractions, their nasal flaring, and their tracheal tugging, which were all reduced. We also were able to perform that P0.1 measurement, which again is a measure of patient effort, which decreased when the patient was taken from a CPAP of 5 to 8. And then as you can see with the EIT image, although they still have hallmarks of asthma, I would say just looking at it and what we noticed at the bedside, it was more homogeneous and more symmetric in terms of how the patient is breathing. So this was a really helpful kind of metric at the bedside. And I think just talking a little bit about the actual improvement of ventilation in comparing the CPAP of 5 and the CPAP of 8, we were actually able to see that the patient had improved ventilation, which is the image on the right, which is the green that represents improved ventilation. And so the thought was that by matching their intrinsic or auto PEEP, we were able to overcome the airway opening pressure, and then gas was able to actually reach previously unventilated alveoli, and then the respiratory system compliance was improved, and ultimately their ventilation improved. So this patient went on to be successfully extubated on a higher CPAP level of 8. And so this was a successful outcome. And I think it really is important in a couple of ways. It shows not only how to manage some of these patients, but it also allows us to see real time kind of what's happening physiologically at the bedside, and kind of proves a lot of physiologic concepts that were previously understood. So there was a 2006 study that showed that by increasing positive and expiratory pressure in addition to pressure support, patients had a more equally match of their intrinsic PEEP and had reduction in their worker breathing, versus those patients that were simply where the pressure support was simply increased, PEEP was left the same. And so I think, again, this just shows how we can monitor that at the bedside in real time. So what about this notion of pendilift? Pendilift is a concept that, again, ARDS is a heterogeneous process. So pendilift is kind of a representation of that. Different alveoli may have different time constants. So a shorter time constant would be one that has a high compliance or low resistance, and thus it will fill more quickly than a neighboring unit with maybe a longer time constant. So after the tidal volume is delivered, gas may move from the faster filling unit to the slower filling unit, contributing to this kind of pendilift phenomena, which is represented in this schematic here. And this is something that we can actually see at the bedside by using EIT. And again, this is a physiologic concept that we've known for a long time, but now we actually have a visual representation of it. And so this patient has what I would define as pendulift. And as you can see, they have this very inhomogeneous lung filling pattern with these areas of lung filling at different times and shifting their ventilation from one to the next. And here's another example of a patient that had pendulift. This was likely as a result of their severe obesity. So you can see that the posterior and the anterior areas of the lung are filling at different times. And again, I want to draw your attention to the fact that this patient was severely obese. And so likely the posterior lung areas of lung had increased resistance or decreased compliance, and therefore were filling slower than the anterior lung units just due to body habitus and chest wall. And interestingly enough, this patient, we were able to overcome the pendulift by increasing their PEEP and their pressures to kind of overcome those variable time constants in the anterior and posterior lung units. And so again, EIT was very helpful in managing this particular patient. So another use of EIT is for monitoring in patients that are on high frequency oscillatory ventilation, or HVOV. This is a tool that is still in research and development, but is a really exciting prospect for the future. As many of you know that have taken care of patients that are on the oscillator, it can be really hard to know what are the pressures that the lungs are seeing and how do we monitor that, and how do we monitor for overdistension and kind of the feared complication of pneumothorax. Historically, we really just have our exam to go off of and then daily chest x-rays to make sure we're not delivering too high of pressures. And I think the case that I presented at the beginning of this webinar really illustrates how unsafe ventilation strategies can lead to severe barotrauma and severe ventilator-induced lung injury. And so what this tool allows for is real-time imaging or real-time monitoring at the bedside as you're titrating the various oscillatory parameters and looking for overdistension. And so again, when we're watching this video, areas that are lighter in color or white are areas that are more ventilated or would be potentially overdistended. Areas that are darker in color would be more collapsed or just have less ventilation. This particular patient, if it looks funny to you, this patient actually had congenital absence of their left lung, and so they had a solitary right lung. And so I think it was even more important to monitor this patient with EIT, given that all of the ventilation was going to their solitary lung. And so I'll just play this video of what we see at the bedside. So again, we have the real-time image, so it's very quick due to the oscillations, but then we're able to slow it down and see really what's happening in real time. And then the image in the bottom left, again, is kind of the average over the last several breaths. And so I think what proved to be very helpful in this patient was we were able to leave the EIT on for about 24 hours while titrating the patient's mean airway pressure. And the respiratory therapists and clinicians could continuously kind of walk by and get a sense over time what was happening to that image in the bottom left. And if we started to see areas that were getting lighter in color, it was maybe a signal that this patient was becoming overdistended. We should investigate that further. And so I'm really excited about kind of the next steps for this feature. And again, this is still in kind of for research and development. So now I want to end by kind of talking a little bit more about what we can do, not only with the ventilation mapping, but also the perfusion mapping. And again, this is a lot of what we're doing is offline analysis using the amplitude of those cyclic changes in lung impedance caused by passage of the cardiac stroke volume through the lung. And it gives us a representation of kind of lung perfusion. And this has been previously shown to correlate well with other measures of lung perfusion. And so just to orient you again, areas on the right, areas in red are lung perfusion. Blue is associated with the heart, and then on the right is the ventilation map. So as you can see in this particular patient, they had most of their perfusion going to their right lung with a little bit going to their left lung. And so there was definitely some differences between the right and left and with their ventilation and perfusion, suggesting some VQ mismatch. So what we can do with these images, we can actually overlay them on top of one another, and then we can get a real-time image of VQ mapping and see the perfusion and ventilation as they relate in real time. And then we can take that one step further and actually put the images on top of one another and then produce a subtraction image, which creates a VQ map. And so again, to orient you, the areas that are darker in color would be areas that are more equally matched between ventilation and perfusion. Areas with this kind of light gray, dark color would be areas that are more, have some perfusion but are more ventilated. And then areas that are in this orange color would be purely ventilated but not perfused. And so this is, again, is just a helpful metric to see where there may be some inhomogeneity and how can we target that with therapy. And so my final case that I'm going to present is a patient that we actually were able to use the perfusion and ventilation mapping to guide management. And so this was a patient with new diagnosis lupus and severe pulmonary hypertension. As you can see, she had severe cardiomegaly on her chest x-ray and also on her CT. And then I want to draw your attention to this left lower lung where most of her lung parenchymal disease related to her lupus was present. When we did EIT on her at the beginning of her hospitalization prior to any therapies, we were able to see perfusion differences that correlated with her CT scan. So again, her ventilation image is shown here on the left, her perfusion image on the right. And as we can see, she doesn't have much perfusion in that left lower area of the lung. And when we do the overlay subtraction image, this area would be mostly ventilated but not perfused. And so what I was curious in doing was, now I knew that the pulmonary hypertension team was planning to initiate therapy with nitric oxide and treprostinil. And so I wanted to get a sense of what was happening over time, as we don't have other great metrics besides echocardiogram to see how those therapies may be affecting lung perfusion. Unfortunately, we couldn't use the pulsatility feature in this patient, and it was for a pretty interesting physiologic phenomenon. So once patients with severe pulmonary hypertension are initiated on therapy, those therapies tend to selectively dilate large arteries. So a lot of that pulsatile energy is lost in those large arteries and not transmitted out to the peripheral vasculature. And so the pulsatility image for this patient showed no perfusion in the lungs, which we were able to find out later was not the case, but it was just a limitation of the technology. And this is called the Wind-Kessel effect. And in talking to our pulmonary hypertensive experts, this is kind of a known phenomenon. So we had to come up with another way of monitoring perfusion on therapy if we wanted to have our true bedside assessment. And lucky for us, the EIT device has a new tool called the VQ, or perfusion tool, that actually is a real-time bedside perfusion scan. And what this entails, it capitalizes on the fact that different solutions have different impedance. And so a hypertonic solution is going to have different impedance as compared to blood plasma. And by using that and injecting it directly into the heart, we're able to trace the blood flow through the lungs and get a true perfusion map. So in this particular patient, they had a central PICC line, and we were able to inject 5 milliliters of 5% sodium chloride and produce this perfusion image that I'm going to show now. So here's the filling in the lungs, and as you can see, she actually has pretty good perfusion in both lungs, particularly in that left lower area of the lung, which had been previously shown to have reduced perfusion. The device itself is also able to produce an actual map, similar to the ones that I did earlier, but I would say a little bit higher quality. So the perfusion map here shows that she had pretty homogeneous perfusion to both her right and left, and actually had improving perfusion in that area that I showed earlier. Here's her ventilation map. It's important to note that this has to be done during an inspiratory hold, as it eliminates the signal from the lungs, and so you get truly just a representation of perfusion. And then you're able to see the distribution across different regions of interest. So anterior, posterior, right, left, and then the various West units throughout the lung, both perfusion and ventilation. And then it produces an actual map of the ventilation and perfusion, with areas being green being matched perfusion and ventilation. Areas that are blue are mostly ventilation, and areas that are red are mostly perfusion. So this is, again, a really exciting tool that I'm excited to use in future patients, as I think it can really guide targeted therapy for some of our patients, especially in the pediatric ICU patients that have severe ARDS and have VQ mismatching. So I'd like to end by just going over some conclusions from what we've talked about today. So in summary, EIT is a powerful tool for monitoring and assessing regional lung ventilation and perfusion in children. We highlighted the importance of adhering to lung protective ventilation strategies with close bedside monitoring with tools such as EIT. EIT allows for identification of recruitable and non-recruitable lung disease, guiding PEEP strategies, and this is the basis for ongoing research studies. There's also opportunities for research into future applications of EIT, including VQ mapping and lung perfusion. So with that, I would like to share my references and open it up for discussion and questions. Thank you all so much for your time, and I will open it up.